Hi everybody, and welcome to our module on HIV drugs. The drugs used to treat HIV infection generally fall into one of four categories. The first group are the protease inhibitors. There are two groups of reverse transcriptase inhibitors. The first ones are called nucleoside reverse transcriptase inhibitors, and the second group is called the non-nucleoside reverse transcriptase inhibitors. And then finally, there are some other drugs that don't really fall into one of the other three categories. Let's start by talking about the protease inhibitors. Drugs in this class include lopinavir, ritonavir, and indinavir, and all of these drugs inhibit the enzyme HIV protease. Recall that this enzyme is a product of the pol gene, and its job is to cleave long polypeptides into smaller functional units. So if you block the protease enzyme, you will block production of important viral components like the enzyme reverse transcriptase, the enzyme protease, the enzyme integrase, and also structural proteins. What this means is that the virus particles cannot mature, so the virus particles will bud off from cells, but they will be non-infectious because they don't have functional elements like all of these things I've listed here so that they can go on and infect other cells. This is a slide from our module on HIV, and these are the three key genes of HIV, and the two we're talking about here are GAG and POL. And so both GAG and POL synthesize long polypeptides that then get cleaved by protease into functional units. So when you block the protease enzyme, you block the cleavage of the GAG polypeptide into all of its functional units, including the P24 protein that's important for the capsid. You also block the polypeptide from the pol gene, which needs to get cleaved to form all these enzymes right here. So you will have decreased levels of reverse transcriptase and integrase and protease when you inhibit the protease enzyme. There are many side effects that patients on protease inhibitors can develop. Some of them are non-specific, like nausea and diarrhea. Many patients on protease inhibitors get hyperlipidemia and hyperglycemia from insulin resistance, and these two features here probably contribute to the higher rate of cardiovascular disease among patients with chronic HIV infection. There is a characteristic fat redistribution that occurs in patients on protease inhibitors. They have loss of fat in their legs and in their arms, but they get increased fat around their abdomen and also at the base of their neck. That's called a buffalo hump. This is sometimes a barrier to compliance because people don't like the accumulation of fat when they're on these drugs. Indinavir has a unique side effect. It can cause kidney stones, and keeping patients well hydrated when they're on this drug is very important. And then finally, ritonavir has a special feature. It inhibits the cytochrome P450 system, so it can be administered at a low dose, which will cause less side effects to boost the effect of other protease inhibitors. And so the primary use of ritonavir in the modern era is to boost the effect of other drugs. For example, ritonavir and lopinavir are used in combination in a drug called Kaletra, and by putting these two in combination, it allows you to use a lower dose of both drugs and have less side effects while still boosting the effects because you inhibit the P450 system. The next class of HIV drugs I'm going to discuss are the reverse transcriptase inhibitors, and before we can discuss these drugs, we have to review the structure of DNA, because recall that the job of reverse transcriptase is to synthesize DNA using RNA as a template. So let's look on the right side of the screen here. This molecule here is called a nucleotide. A nucleotide has three components. First, it has a base. In this case, the base is guanosine, and that base is attached to a ribose sugar molecule, which I'm circling right now. And then that ribose sugar molecule is attached to a phosphate group. And so when all three of these elements are present, this is called a nucleotide. And DNA is synthesized by linking different nucleotides together. So let's look at the left side of the screen here. This is a molecule of DNA, and we've got a nucleotide right here attached to a cytosine base, and it's attached to another nucleotide via this phosphate bond here. So in this manner, DNA is synthesized by taking these nucleotides as building blocks and linking them all together in long chains. Shown on the screen are the four nucleotides used by reverse transcriptase to synthesize DNA from RNA. Note that each one of the nucleotides has a ribose sugar, a base that is attached, and three phosphate groups. Therefore, these are the triphosphorylated form of these nucleotides. Reverse transcriptase will pick up these triphosphorylated nucleotides, which are found inside of our cells, and use them to synthesize a strand of DNA from RNA. The way that the nucleoside reverse transcriptase inhibitor drugs work is they mimic the structure of one of the nucleotides on the screen here. For example, they mimic the structure of cytidine or adenosine or thymidine or guanosine. Reverse transcriptase will then pick up the drug and incorporate it into a growing strand of DNA. Once the drug is incorporated, the chain cannot grow any further, and thus the chain terminates. The nucleoside reverse transcriptase inhibitors include drugs like zidovudine and lamivudine and tenofovir and didanosine. And all of these have chemical structures that are similar to the nucleotides, so they look like the A, C, G, and T building blocks of DNA. However, all of them lack the OH group through which the different nucleotides attach to one another. I'll show you a picture of that in a minute. This means that once one of these drugs is incorporated into a growing DNA chain, it terminates chain elongation. As a result, reverse transcriptase can't work anymore and it becomes inhibited. So these drugs are referred to as inhibitors of the reverse transcriptase enzyme, and that's true, but they have this very unique mechanism of terminating the growing DNA chain that you need to understand. So as an example, let's look more closely at the drug zidovudine. Zidovudine was one of the first HIV drugs on the market. It was called AZT. And this is the chemical structure of zidovudine on the left, and this is the chemical structure of thymidine on the right. And you can see that they are very similar. Zidovudine has the same base as thymidine, and it has a ribose sugar just like thymidine. What's different is that thymidine has a hydroxyl group right here, whereas zidovudine does not. And recall that it is this hydroxyl group that gets linked to the next nucleic acid. This means that once zidovudine is incorporated into a growing DNA chain, that chain cannot be grown any further because there's no way to add another nucleic acid. The hydroxyl group is missing. And the carbons on the ribose of nucleic acids are often numbered. So this is called the 1 carbon, this is the 2 carbon, and this is the 3 carbon right here. So what we often say about these NRTI drugs is that they lack the 3' hydroxyl group, and that's because this is the 3' carbon right here that the OH is attached to. And here's a schematic showing you how zidovudine gets incorporated into a growing DNA strand. This is the structure of zidovudine at the top left of the screen. There are kinase enzymes that add phosphate groups to the zidovudine molecule. And remember what I said before, these molecules must be triphosphorylated before they can be incorporated into a growing strand of DNA. So successive phosphorylations lead to a molecule which has 3 phosphate groups attached. This is picked up by reverse transcriptase and incorporated into a growing DNA strand. However, once the zidovudine molecule is part of the strand, other nucleotides cannot be added, and therefore DNA strand growth terminates. Now, I've been referring to this drug class as the nucleoside reverse transcriptase inhibitors, but we need to pause here and define a little terminology before we go any further, and we need to talk about the difference between a nucleoside and a nucleotide. So let's look at this picture over here on the right. This is the chemical structure of the nucleotide adenosine. It has a base right here, and this base is adenine. That's why it's an adenosine molecule. It also has a ribose sugar molecule here, and then finally it has a phosphate group. So when all 3 elements are present, the base, the ribose sugar, and the phosphate group, we call that a nucleotide. When it is only the base and the sugar and the phosphate group is missing, and instead there is just a simple hydroxyl group attached here, in that case we call it a nucleoside. And most of the drugs I've been talking about up to this point are nucleoside reverse transcriptase inhibitors. In other words, they mimic the structure of a nucleoside. They do not have any phosphate groups attached to them. So the reason I explained all that to you is because tenofovir is different from the other drugs in the NRTI class. Tenofovir is a nucleotide. It contains 1 phosphate group. This is the structure of tenofovir on the screen here, and you can see that it has a phosphate moiety. Tenofovir still has to become triphosphorylated, so 2 additional phosphate groups have to be added to the molecule, but once that occurs, it can inhibit reverse transcriptase as a mimic of adenosine. Zidovudine and lamivudine and the other drugs in this class are nucleosides. This is the structure of zidovudine up here in the top right, and you can see that it does not have any phosphate groups attached. These drugs have to be triphosphorylated in order to become active. Tenofovir only needs to be diphosphorylated and just have 2 phosphate groups added. So here's a schematic of how tenofovir works once it gets inside the cell. So it comes with that 1 phosphate already attached. There is a kinase which will add a 2nd phosphate, and then another kinase which will add a 3rd phosphate. Once it has 3 phosphorus groups attached, it'll be incorporated into a DNA molecule by reverse transcriptase, and then that will block chain elongation, and the DNA chain can no longer grow. An important side effect of nucleoside reverse transcriptase inhibitors is mitochondrial toxicity. So recall that mitochondria have their own DNA. Some people think that mitochondria may have evolved as very small bacteria that became incorporated inside of eukaryotic cells. But however it happened, the mitochondria have their own DNA, and they have an enzyme called DNA polymerase gamma that helps synthesize DNA for the mitochondria. And this enzyme can become inhibited by the reverse transcriptase inhibitors in the same manner that reverse transcriptase gets inhibited. And when this happens, you can lose mitochondria. So what are the symptoms of that? Well, mitochondria are found everywhere, but some of the symptoms that predominate include peripheral neuropathy, so pain and paresthesias can occur, muscle soreness from myopathy. Patients with mitochondrial toxicity can develop pancreatitis. And then finally, one of the most dangerous potential effects of mitochondrial toxicity is lactic acidosis. So recall that the mitochondria are responsible for oxidative phosphorylation. So when you lose mitochondria, you can lose oxidative phosphorylation and the body will switch over to anaerobic metabolism. This means a lactic acidosis can occur, and there are cases of severe, life-threatening lactic acidosis in patients taking NRTIs that have been reported. And the way this would present in a board question would be an HIV patient on chronic therapy who develops hyperventilation and a very low bicarbonate level, and they have signs and symptoms of a lactic acidosis, and it's coming from mitochondrial toxicity and the loss of oxidative phosphorylation. Each of the drugs in the NRTI class have certain side effects that are more or less common, and I'll go through some of the important ones now. Zidovudine, you'll recall I said, was the first antiretroviral medication used for HIV. It was marketed as AZT. And an important side effect of zidovudine is that it can cause bone marrow suppression. So the zidovudine can get incorporated into growing DNA strands in the bone marrow just like it does by reverse transcriptase, and this inhibits synthesis of new cells in the bone marrow. This can be improved if you give bone marrow stimulating medications like GCSF or EPO. Zidovudine used to be used to prevent maternal fetal infection, so it was given prenatally to mothers and then given to the infant after birth. Now there are new World Health Organization guidelines that actually recommend a multi-drug combination to prevent transmission, but you'll see in some older documents and textbooks that they recommend zidovudine for mothers and babies. I've listed on this screen the names of some of the commonly used nucleoside reverse transcriptase inhibitors. One thing you should know is that many of them go by two names. So for example, didanosine is often called DDI, and that's an abbreviation of its chemical structure. Lamivudine is often called 3-TC. On this slide, I've shown the nucleotide that the drug mimics, and then finally I've listed any special comments in this column on the right. So for zidovudine, you should remember that it can cause bone marrow depression. Abacavir has a unique side effect. About 5% of patients get a hypersensitivity reaction. They will get fever and a rash, sometimes respiratory distress or GI upset. This can often look like the patient has developed an opportunistic infection, but it's actually a reaction to the drug. DDI often causes pancreatitis. D4T can cause lipodystrophy, like I talked about before with the protease inhibitors. Lamivudine is one of the least toxic of these drugs, and one thing to know about lamivudine is that it can also be used for hepatitis B. Recall that hepatitis B also uses the enzyme reverse transcriptase, and I talk more about using lamivudine in the viral hepatitis modules. And then finally, tenofovir causes a lot of GI upset, nausea, vomiting, diarrhea. This is often a limitation of using this drug in patients with HIV. There's a special side effect of tenofovir you should know about because it ties in with nephron and renal physiology, and that side effect is the Fanconi syndrome. This happens to a small number of patients who take tenofovir. They lose their proximal tubule function in the nephron. As a result, they spill protein in the urine, they waste phosphate in the urine, they can have glucose appear in the urine. They can develop a metabolic acidosis and low phosphate levels in the blood and low potassium levels in the blood. And I talk about all this in more detail in the nephron physiology modules, but the bottom line is this could be presented as a board question of a patient on tenofovir who develops polyuria and muscle weakness. Tenofovir is similar to another HIV drug called adofovir, which was pulled from the market. Adofovir used to cause this Fanconi syndrome in about 50% of patients. And the side effects of all the different NRTIs are difficult to keep straight. An excellent resource is the AIDS Info website, which has guidelines for the use of these drugs, and it lists all the side effects and the indications for when to use them. The next group of HIV meds are the non-nucleoside reverse transcriptase inhibitors, and these drugs also inhibit the enzyme reverse transcriptase, but they do not mimic the structure of nucleosides. Drugs in this class include nevirapine, efavirenz, and delavirdine, and this is the structure of nevirapine on the screen here, and you can see that it looks nothing like a nucleotide. These drugs inhibit reverse transcriptase by binding to a different site from the NRTIs. These drugs work more like traditional enzyme inhibitors. They bind to reverse transcriptase and modify the protein so that it can no longer function. These drugs don't have to be phosphorylated like the NRTIs, and they do not suppress the bone marrow because they only affect reverse transcriptase. They don't affect other DNA synthesis enzymes. And one thing to know about the NNRTIs is that they are not effective for HIV-2, which is the type of HIV found in West Africa. HIV-2 has a different reverse transcriptase that is not inhibited by the NNRTI drugs. Side effects of the NNRTI class include GI upset. Some patients develop a skin rash. Very rarely, this can become severe and progress to things like the Stevens-Johnson syndrome. And then you should know that these drugs are metabolized by the cytochrome P450 system in the liver. This means that their levels can go up or down when they're co-administered with other drugs. There are a lot of drug-drug interactions on people taking NNRTIs. In addition, different members of the NNRTI class have different effects on the P450 system. For example, nevirapine is an inducer of that system, delavirdine is an inhibitor, and then efavirenz has a mixed effect on the system. So drug-drug interactions are a major issue in patients taking drugs from the NNRTI class. Finally, let me mention 3 other HIV drugs, and the most important thing to know about these drugs is their mechanisms because they all inhibit key elements of the virus particle. The first drug is raltegravir, which is an integrase inhibitor. So recall that the integrase enzyme inserts viral DNA into the cellular genome. So when you lose activity of the integrase enzyme, you disrupt the viral life cycle. And enfuvirtide binds to the surface molecule GP41, and recall that this molecule is important for fusion of HIV with cells and entry into cells. So when you bind GP41, you inhibit fusion and entry of HIV. And then finally, maraviroc is a drug that blocks the CCR5 receptor on macrophages, and recall that those M-trophic versions of HIV need to bind to this receptor in order to gain entry into cells. And that concludes our module on HIV drugs.